Our next session is on acute stroke care and rehabilitation. For this session, I'd like to invite on stage our chairpersons, Professor Dr. Shamur Bishwas sir, Professor of Neurology, NRS Medical College and Hospital, sir. Professor Dr. Pankaj Kumar Mondol sir, Head of the Department, Physical Medicine and Rehabilitation, RG Medical College and Hospital. For the first session, we have acute stroke care and rehabilitation. The first session is a recorded session by Dr. Kaushik Sundar, consultant of the neurointervention team at R. N. Tagore Institute of Cardiac Sciences. For the question answer session will be attended by Dr. Arvind Gautam.
This is a very challenging session, post-lunch session.
Respected dignitaries on and off the stage. I'm Dr. Kaushik Sundar and I've been invited to give a talk on acute stroke management. At the outset, I would like to sincerely apologize for not being there in person. I would like to thank RehabCon 2025 for having me on this podium. Due to some personal reasons, I'm not able to be there right now. Anyways, my team, my fellow Dr. Arvind will be there around. So my topic today is acute stroke management, and let me see if I can, throw some light into the subject for the next 10-12 minutes. So whenever we talk about acute stroke management, these are the two numbers that you should remember when you're taking home something on stroke. The first thing is, what is the time window for thrombolysis and what is the time window for clot retrieval or mechanical thrombectomy. So the best time for thrombolysis is now. Now meaning the moment the stroke happens, if you're able to thrombolyze the patient then and there, that is probably the best time where you can do a thrombolysis. But obviously that's not going to be easy. So the next best thing that you can probably do would be to try and get these patients into hospital less than 4.5 hours time. So within 4.5 hours, if the patient is coming into the hospital, then that is the best window for thrombolysis. Now regarding mechanical thrombectomy, thankfully we are a little more flexible with the time. It is best done if it is done within the first 6 hours since the patient was last seen normal, but it can be done up to 24 hours as well. So sometimes patients who are far off, this is only for large vessel occlusions. So if you are going in and doing a procedure to retrieve a clot, then the best time window in which you can do this is possibly 24 hours. So this is somewhat similar to the coronary scenario as well. So we try and, if you want to thrombolyze a patient with STEMI, it is almost immediate, but PTCA can be done a little later as well. So, but still the idea is the sooner the better. Whether we do it thrombolysis or do thrombectomy, the sooner the better. That would be the best way to go. So ideally, stroke is an emergency. We all know that. And the patient should ideally reach the hospital in less than 3 hours, but at least should receive treatment within the first 24 hours from the stroke onset so that the recovery is better. I'm not going through this per stroke, how much time if you delay and what is the loss that happens. But the simplest way to understand is for every second lost, a patient loses his age by around 8 to 9 hours. And for every hour lost, the patient ages by around 3.5 to 4 hours. So you know that if there's a patient with a lacunar infarct who presents late to the hospital or presents late to the rehab center, then if this gentleman or if this lady was a working woman in his or her home, then suddenly she becomes a person who is now not able to work anymore or not able to do things independently. And suddenly this patient has become an independent person inside the house, like an elderly person. So the 40 years person develops a stroke and it's bedridden, and suddenly this patient becomes almost like 60, 70 years old. So every stroke, it's not that just the number of neurons that we lose, it is also how much you get older by each stroke. You will not be able to go to the gym anymore. You will not be able to drive a car. You will not be able to do things independently. And that is scary. So of course, we know all this to be fast. Due to want of time, I'm not going through this. But the simple way to remember for warning signs for stroke is if there is balance problems, visual problems, facial deviation, if there's an arm or leg weakness, if there's a speech disturbance, then it is time for these patients to reach the hospital. Okay, so the best way to make sure that patient receives good hospital care for stroke management is if there is a pre-hospital notification. What it means is if there is an ambulance that is able to get these patients to another hospital, then it will be best if the ambulance pre-notifies the hospital that we are probably getting in a patient with stroke, so that the stroke team, the emergency team, the radiology team, the nursing staff, everybody is ready to receive this patient, and either we give a thrombolysis for this patient or we and do a mechanical thrombectomy for this patient. But the most important prerequisite for this step is that you have to take a patient to a CT ready hospital. At least a CT scan should be available. Because unlike heart attacks where we can do an ECG and a tropoe and make a diagnosis of stroke, we need at least a CT scan to decide whether we are going to do thrombolysis or thrombectomy for this patient. So this is one such patient who had come to our hospital in Howrah unit. She was 72-year-old. She had suffered a stroke. And then the Narayana Health and Howrah unit had activated the stroke code. And then we did a CT over here, and we communicated with the WhatsApp. It was almost like a telestroke. And what you can see over here is what we call as a hyperdense sign. So the moment we saw the hyperdense sign, the hospital over there from NH Howrah informed us that this is a large vessel. We are shifting it to Arentagore. So this is a pre-hospital notification. So she was immediately shifted from the Howrah to the Mukundapur unit. And this is probably 40 minutes time, but still we were prepared on the other hand. So the moment the patient came to our hub center, that is from the Howrah unit to the Mukundapur unit, which is called the Spoken Hub, we did a CT angio here and we saw a large vessel occlusion here. So what did we do? We took her to the cath lab and immediately we did a mechanical thrombectomy and we opened this vessel up. Now, 72-year-old lady with a large vessel occlusion on the right side, you will all expect her to have a left-sided weakness and, a patient will probably have a gaze preference and all that. But let me show you what happened to this patient. This is a CT after 12 hours. Very good. But more importantly, this is the patient voice.
उस साइड में देखिए जानते हैं इस डॉक्टर को नहीं ठीक है
So the gaze has started improving.
ऊपर ऊपर और ऊपर
She started moving her left upper leg. The next most important team in the hospital is probably to have a very, very good stroke team, predominantly in the emergency. It's a class 1 level B evidence. And all stroke patients who come into the hospital should have a stroke scale evaluation, either in NIHSS or RACE, so that we understand that during the course of stay in the hospital or after rehab, at the time of discharge, what is the kind of severity that the patient had and how much we have improved. It also helps us to audit the kind of work that we are doing in our hospital. Brain imaging. This is one important thing. I would probably spend a little more time over here. The one thing that we need to remember is for acute stroke management for the first 24 hours, a simple CT scan would suffice. You don't need an MRI. You don't need an MRI to prove whether it's an infarct or a hemorrhage and all that. It's just a simple CT. All patients should receive CT, and all patients with suspected stroke inside the emergency room should receive a CT within the first 20 minutes. So in our hospital, we try to find ways to keep this timeline open. We activate a stroke code and we try and finish the CT in the first 10 to 12 minutes. That's our target time. That's a key performance indicator. And Madhushri will vouch for it that we have been doing this for the last, 6 to 7 years. And we have been always been able to get this on target. So it's not 50% for us, it's 100%. What are the other diagnostic tests you need? Not much. The only thing that you need before you do a CT would be a sugar test to understand if there is hypoglycemia or not. The role of chest X-ray is not clear. You don't need to wait for a chest X-ray. You don't need to wait for any other bloods. ECG and tropoe is fine, but still do not delay a CT or do not delay IV thrombolysis. So the simplest investigation that you need at the time of the patient entry into the emergency, apart from the CT scan, would probably be the blood sugars. What are the thrombolytic agents we give? If the patient presents with 4.5 hours, we have 2 thrombolytic agents. My personal favorite is this drug called tenecteplase. And the tenecteplase drug, we give it because it's just a simple bolus administration. It is around 20 milligram vials that come in, and we give around 0.2 mg per kg body weight. Simple, give it and forget it kind of thing. So this is one patient who came to our hospital. You can see over here that the patient is having a right carotid that can be seen, but the left carotid is not seen. And the patient has started developing infarcts on the left side of the brain. We thrombolized her. So onset of a stroke was 10:30, presented to our hospital at 11. By the time the brain imaging was done, it was 11:40, and we thrombolized with tenecteplase. And so when still it was a large vessel occlusion, so we took her up for the angiogram. So when we took her up for angiogram, now we can see that the carotid artery is still visualized. It is the MCA that is not there. So the thrombolytic agent had opened up the carotid artery by the time we went in. And more importantly, when we wanted to go in to retrieve this clot, even this had opened up. Simple medications, the entire clot got busted. And this is the patient within 12 hours after the procedure. Remember, she's a 80 plus lady and she had started walking.
Very good.
Thrombolytic agent itself
Very good.
can sometimes open up large vessels. Though the chances are very less
Very good.
that thrombolytic agents can do wonders in large vessels,
good.
but still they have a role.
Very good.
Guidelines say that
Very
you should still
good.
thrombolize patients
Very
who come in the
good.
window period
Yes,
over and above
good.
mechanical thrombectomy. Okay, so next question would be the BP management in thrombolytic, in acute stroke. So if the patient is going to undergo thrombolysis or mechanical thrombectomy, then and only then you try to bring the BP low aggressively. That is less than 180 systolic and less than 100 diastolic. But if you are not planning any thrombolytics or mechanical thrombectomy for the patient, then the systolic blood pressure needs to be kept less than 220 and less diastolic less than 120. In simple words, if the patient is receiving IVT or MT, then you have to give infusions to reduce the BP. If the patient is not receiving any acute therapy like thrombolysis or mechanical thrombectomy, you can still manage the blood pressure with oral medications like amlodipine and telmisartan. It's a very simple way to go. So as I told you before, if the only imaging that you require at the time of acute stroke management is a CT, but if you were doing a mechanical thrombectomy like our center does mechanical thrombectomy 24/7, and if we are doing it, then the only other investigation that we want is a CT angiogram. But remember, CT angiogram, since it is a contrast agent, most of the radiologists will say that we need a creatinine. We don't require serum creatinine for patients who are undergoing mechanical thrombectomy or in an acute stroke setting, unless the patient is a documented CKD patient. Otherwise, if the patient is just wheeled into the hospital with an acute stroke with no history suggestive of kidney problems, we can straight away jolly well do a CT angio without waiting for the creatinine. Again, this is one more patient for whom we did a mechanical thrombectomy. This was a patient who came in with a large right MCA territory stroke. This was beyond 6 hours. Right now, we are having studies that talk about a large core infarcts. We can see here a good amount of right MCA territory that is gone. So she was shifted to our hospital, and then we did a mechanical thrombectomy for her. I'm just showing you some videos about this mechanical thrombectomy. You can see the internal carotid artery, and then you can see the entire right part of the brain is not perfused. And then when we did occlusion, you could see here that this right M1, the MCA, is completely occluded. Then what we did was we went ahead and did a mechanical thrombectomy for this patient. You can see here that the stent retriever was being deployed, and the stent retriever was slowly withdrawn, and the clot was also removed. Want of time, I'm just rushing through this slide. And so this is the right MCA clot that you had seen before, and now that it completely opened up, the patient was doing very fine. So this was the patient. She did have some residual infarcts, but after 7-10 days of hospital care, she did well and she went home. So other FAQs, quickly I'll run through them. Is there any role for hemodilution agents like albumin and pentoxifillin? No, we don't give this in acute stroke. Neuroprotective agents like citicoline or edaravone, again, no role for acute strokes. You could give them in rehab therapy, but in acute stroke management, there is no benefit. Establishing stroke units is very, very important. You could identify ICU beds and hospital beds where you can keep these patients in, and designated wards and areas with designated nurses help these patients out. DVT prophylaxis, always recommended. The most common DVT prophylaxis we give is a pneumatic compression, that is intermittent pneumatic compression stockings. Unvaccinated low molecular weight heparin can still be given, but please avoid TED stockings or elastic stockings, as they can cause sores. So some don'ts: don't give steroids. There is no role for anti-epileptic drugs prophylactically in patients with acute stroke. Better than echocardiography, do an ECG for all these patients. Echo is only required if you are suspecting a valvular heart disease. So, as I told you, now we have started grooming patients for up to 24 hours. Probably we are going more from time windows to tissue windows to see whether we can even salvage patients beyond 24 hours with acute ischemic stroke. So to conclude, guidelines are excellent tools to manage patients with acute ischemic stroke, but I still feel stroke treatment is a very clinically oriented, tailor-made decision. And I cannot emphasize this fact more, that even after a very, very good acute stroke therapy, a lot of emphasis has to be given on rehab. And my colleague and a very good friend, Dr. Madhushri, will probably follow this talk on rehabilitation for acute stroke. And if there are any doubts, I'm sure my team member, Dr. Arvind, is there around to help you guys out. Once again, thank you for this opportunity, and a very, very big sorry for not being able to be there in I don't know, not being able to be there in person to deliver this talk. Probably next time I'll do even a better job. Thank you.
Now, Arvind is here for any questions from the audience.
If you're suspecting a large vessel stroke, like in CT, you have a dense MCS sign, and the patient has presented within 1 or 2 hours, would you still what is the recommendation? Still going for thrombolysis and then evaluating for thrombectomy, or you can straight away go for mechanical thrombectomy? I mean, because in large vessel stroke, we often find that thrombolysis may not be very successful.
Good afternoon, everybody. First of all, I would like to thank all the faculty members on the dais and off the dais for providing this valuable opportunity. And to answer this question, as per guidelines, we thrombolize the patient and then we take the patient for mechanical thrombectomy.
Fine.
Now, there are two advantages for this. One is the clot permeability. So, the clot becomes more permeable that at times, even before the mechanical thrombectomy, the patient might recur, so that the patient might not require an additional procedure.
Yeah. So
The second is
used to be given the chance to recover before it.
very true, ma'am. And the second is, if the clot becomes more permeable, then the suction thrombectomy would be pretty easier for us to remove the clot, so that the success of the procedure would be pretty higher.
I understand.
So the chances of reperfusion will be 20 to 30% higher if the patient is thrombolized.
Fine.
But there is one disadvantage, that is whenever we are doing a mechanical thrombectomy, we start the patient on heparin. That is to make sure that the system is patent. But now when we thrombolize the patient, the on-table heparin, the dose which we conventionally use is 3000. So we reduce it to 1000 to make sure the patient does not have a hemorrhagic transformation, nor the patient does not bleed during the procedure.
Thank you. That
Thank
was
you.
nice.
So please.
Just one question. See, in an acute stroke patient, the patient having the cerebral aneurysm, in that case, do you suggest the thrombectomy or not?
Sir, I'm sorry, sir. Whether is it an unruptured aneurysm or ruptured aneurysm in the past or in the present context?
In the present attack, there is no rupture of aneurysm. CT scan is found patient having the cerebral aneurysm and the patient having the acute stroke. Do you suggest the use of operation or not?
Sir, we proceed with mechanical thrombectomy, sir. We proceed with mechanical thrombectomy. For this, the procedure is slightly different. We make sure that we use bigger equipment so that there is no dissipation or there is no chance of the rupture of the aneurysm during the procedure. So the materials we use would be slightly different. The materials which are more compatible and the chances of, for example, we would be using a stent driver rather than suction aspiration device, where the chances of rupture would be slightly higher with the suction aspiration. In that context, we would be using a stent driver, sir. Stent retriever. So we just deploy the stent at that site, we remove it back, sir. Thank you.
There is no more questions.
Thank you. Thank you, doctor.
Thank you. Thank you very much.